cool. All right, so can we all see what the heck is up? Okay, cool. So, put you over here. Let's find out. I just need to find a good place for you guys. Okay, so, all right, so we left off with mechanical stress. So we talked about the hormones and stuff, okay? That is something that I know that they ask about on the exam, and like they don't just like blatantly ask you about it. They just ask you for like, they'll tell you about a situation or something, and then they'll ask you about what hormone is, what's happening, you know what I'm saying? Or like if you were the physician or whatever, and it would be like, so and so's blood calcium is really high, like what are we supposed to do? So it's like those trends are really important to know, and if you know one, you kind of understand the other one, right? So that picture that I posted, or the picture that's in the last session, and all of that is on YouTube, so you can go back and watch just like the hormone piece or whatever makes you happy. You don't have to go watch those right now, but I would recommend them before the test. I think it'll make your life a lot easier. Okay, so can y'all hear me okay? I'm in the engineering building, so I'm just like trying not to shout.
You're good.
Okay, cool. Okay, so bones mechanical response to stress. So like we talked about last time, we talked about in bones and like stuff like in the show Bones, that depending on what you do in your lifestyle, your bones will remodel and reconstruct to support that. So weight bearing, this needs to go away. Cool. Weight bearing stress, right, or muscle pulling can have effect on bones. So there's something called Wolff's Law, which pretty much just tells us that as a bone is needed for more strength, right, as there's more demand placed on them, it will accommodate for that. So bones grow or remodel in response to demands placed on them, right? Whether that's we're bodybuilding or we're sitting on the couch and there's less demands, you know what I'm saying? Whatever demands are placed on them will do that, okay? So they bend on one side and stretch on the other side, right? And they compress on one side and stretch on the other side, right? And so that's just kind of telling you about muscle attachments and where things go in response to where they're needed, right? So as we grow, one side is going to stretch, the other one's going to compress, one will bend, right? That's why we have fractures and stuff, is because if you're not using the muscle and the bone correctly, right? If you get a blow to the knee laterally, right, that we're not made for that. So that's why you end up like tearing your ACL or your MCL or your LCL, because your bone's not made for that. Okay, so the bending stress is greatest in the diaphysis. What's the diaphysis?
Middle of the bone.
Yeah, and what are the ends of the bone? Not Christian, someone else.
Oh.
The right? The E word.
the epiphyses. I know it's a lot of like, I don't know what I'm saying. Okay, so yeah, so in the middle, right, because a lot of bones attached in the middle, right? So the diaphysis is where the stress is greatest. Okay. Actually, so in talking about the show bones, whatever hand you have, your bones will result in that, right? Because you're using your right hand a lot more if you're right-handed. So your bones will be thicker and stronger because you're using it more, especially if you play sports or something like that, or like, especially like in tennis, right? Because you have a forehand and a backhand, but your driving force is going to be your dominant hand. So that's going to be much stronger. Or in volleyball, usually you're using one hand for hitting, one hand for, you know what I'm saying? So your bones will result in that, your handedness. So you can tell from an x-ray which hand you use more, right? And some people have like, especially if you play sports where you're like only using one hand, like one of your forearms will be like much bigger than the other forearm. Yeah. She's like, I don't know. Okay. So curved bones, right where they're thickest, are most likely to buckle. Okay. So let me think of an example. Curved bones where they're thickest. I don't know. Let me look up an example, because I can't think of one off the top of my head. Okay, this is a good, so your radius and your ulna, right? So where they're thickest, right, they'll end up buckling. So right here, y'all can see this, right? Yeah, so because they're not, and so that's why I was having trouble, because they're not really curved, but they are, right? So they're where they're thickest, right? They might not be as good at distributing the force or the weight, and so they might end up buckling there. Okay, all right, we're going back. Okay, so trabecula, all right, trabeculae, right? They form these trusses, right, under Wolff's law, and I'll let you write that, and then I'll show you what a truss is. Okay, this thing, there's not a good place for you, okay? Okay, so these trusses are pretty much, right, so trusses are used a lot in, literally in architecture, right? So the Eiffel Tower is made up of a lot of trusses, not trusses, right? So it's pretty much just lots of like intertwining, I don't want to say like rods, right, of trabecula that end up strengthening the bone. So let's see. Well, we can use this. So in here, right? Okay, so because if we need more bone because we've had more stress placed on us, we're going to make more trabecula, right? And so trabecula they don't look like this, but this is in response to lots of stress and mechanical need. It'll form more grooves and more areas where there are trabecula to provide more support. Does that make sense? So as we're making more bone, we're making more trabecula because we want to make sure that we're stable in there, right? It's just like in the Eiffel Tower, right? If the Eiffel Tower was a bone, right, which doesn't super make sense, but if the Eiffel Tower was a bone and it was going to grow, it would need to make more of these interlockings so that it was strong as it grows up or as it grows out, right? Does that make sense? Okay, cool. Okay, so this is not my friend. Okay, so bones of weightlifters have large bony projections as opposed to those who are on bed rest. They're small, right? Can someone tell me why a weightlifter would have larger bony projections?
Because they're under a lot more stress.
For sure. And then not Christian. How about people on bed rest? Why would they have smaller atrophied projections? Why would they have atrophied or small projections for people on bed rest as compared to bodybuilders having big projections? Let me see if you're muted. I can't hear you talk if you're trying to talk to me. So people
Because
on
of the lack of stress on the bone.
for sure, that sounds great. I think that was Heather, right?
Yes.
Okay, sorry, I just can't say your pictures. Okay, so exactly. So because we're not putting any stress on the bone, right? We're on bed rest, we're not supposed to move around. Our bones are going to adapt for that, and we're going to have smaller projections. Okay, so mechanical stress causes remodeling by producing electrical, no. There definitely needs to be another word for that. Oh, this is 11. Electrical? Please hold, because that doesn't make sense. Okay, maybe it's electrical signals. Maybe I shouldn't write signals. Okay, so mechanical stress causes remodeling by producing electrical signals, right, to tell the osteoclasts and osteoblasts to create more bone, right, to remodel and create more bone when we need it. Okay, so we pull and that tells the bone that we need to make more. Okay. Okay, hormonal control determines when or if remodeling occurs based on calcium levels. So we talked about last time how calcitonin and a parathyroid hormone have a lot to do with your blood calcium levels. And so if we have a lot of calcium in our blood, right, are we going to make more bone or not?
Repeat that. I was spacing out.
Okay, so we're talking about how calcium levels will tell us whether or not we need to make more bone. So
Hmm.
remember, parathyroid hormone, does it increase or decrease blood calcium levels?
I think it increases.
Right, and so calcitonin decreases calcium levels. So if we have a lot of calcium in our blood, okay, we are making or not making bone. If we have a lot of calcium in our blood, are we making bone or not making bone?
Making.
No, because clasts are breaking down the bone to release the calcium into the bloodstream, right? Does that make sense, Heather? Okay, so go over your hormones again, because I want to make sure that we get through a lot of this. So based on your calcium levels, right, then you can tell me what your osteoblasts or osteoclasts are doing. And because of that, we can tell if we're making bone or not. Does that make sense, right? Whether there's a lot or a little, right? Whether we're depositing the calcium into the bone because we need more, or we're releasing it because we don't need it. Does that make sense, Christian? You lying?
No, it's good. I was just had things switched around.
Okay, and then your mechanical stress tells you where that happens. Or down to this. Hey, Mary, are we good? She's like having trouble. Let me know if you need anything, Mary. Okay, so calcium levels and mechanical stress determines where it happens. So if we have a lot of calcium in the blood, that means that we're not necessarily making bone. But if we have less calcium in the blood, right, because we're making bone, the mechanical stress will tell us where we need to put that calcium back to make more bone. Yeah. Thoughts, feelings, hopes, dreams. Okay. All right, so now we get to talk about fractures, which are super fun, and it's almost like irregularities. Okay. Hey Mary, will you shoot me your UID in the chat for me to look at later so I can write that down? Okay, so for fractures, I know this one's a little blurry. All right, so there are three classifications of fractures, right? So we have position of your bone ends, right? How complete it is, and if it penetrates the skin. So after you fracture, where our bone ends are, if the break is complete, or if it's come out of the skin. So your bone ends can be displaced or non-displaced. So non-displaced means that they're in a regular position, right? The bone ends did not move. Your epiphyses did not move, okay? And then displaced means the epiphysis did move, okay? Completeness, right? If it's complete, that means the break is all the way through the bone, right? We've chopped it in half, or not necessarily, but we've gone through the whole bone, okay? And then incomplete is not all the way through. Maybe it's a crack, maybe it's like a bunch of little hairline fractures, okay? And then skin penetration, right? Y'all have heard these open and closed. Open is when we've penetrated the skin, right? When the bone comes out of the skin, right? That's a compound fracture, right? But when it's closed, the skin is not penetrated and it's a simple fracture. So most likely the way he'll test you on these is he'll give you a scenario and he'll tell you, he'll be like, this is a non-displaced fracture, incomplete, like a closed, incomplete, non-displaced fracture. And he'll be like, tell me what that means, right? And he'll have like normal, right? He'll like have the list of like regular terms of what they mean, and he'll give you that scenario and make you tell him what that means. Like, how does that fracture look? Okay. So a lot of the time they test these together and then just put it in one question.
I'm opening my door if you don't.
Is everybody good? Are we dead? We died.
Sorry, I have a question.
Yeah.
What is the word positions of bone ends after?
F/X is fracture. Just like RX is prescription, FX
What?
is fracture.
Thank you.
Angel, you good? Are you good? Do I need to call somebody? It's a joke. Yeah, so FX is fracture. All right, so bone repairs. So in treating this, we reduce, right? Treatment a lot ends up being reduction a lot of the time, and reduction means realignment of broken bones. So if you've ever seen anyone on a field and the PT or the AT runs out there and they like pop pop it and all this stuff, and then the person usually screams because it's, you know, it's pretty rough. They're putting it back in place, okay? And so we do that, and they only do it if they feel comfortable or if they think that it's right. And they reduce fractures because the longer that the bone sits like that, the muscles will inflame, right? Because they know something is wrong. And so if they know something is wrong, they're going to inflame to try and keep it tight, just like we would wrap it and keep pressure on it. The muscles do that for us. And so the longer you wait, the harder it is to put it back, right? Or especially in the knee, if it goes backwards or forwards, because there's a vein, a nerve, and an artery right there, you want to make sure that that bone hasn't squished anything, right? It's not obstructing anything, because then we obstruct blood flow or nerve endings, which makes it harder to feel that later. Or sometimes, Eric is here. Welcome, Eric.
He's here. I was waiting.
Oh my gosh. You're so funny. 26 minutes in the session. Anyway, so you reduce a fracture to make sure that we're putting it back in the right spot, right? They'll usually reduce it and then they'll send you to the hospital, okay? And then your surgeon's going to look at you and figure out what to do. Eric, we're on session 11. We're finishing the end of session 11 right now.
Okay, thank you.
How was your swim, Eric? Yeah,
I
last
didn't
week.
go swimming. I'm not gonna tell you why I was late.
Okay.
Okay, no, it's the judgment-free zone. You can tell us.
The ice cream truck came.
Oh, that kills me. That's funny.
Are you for real though? Was that a for real reason?
It only comes on Tuesdays. I'm not gonna miss my chance.
Okay. Eric is a reminder that you should always live life to the fullest. Okay, so
Thank you.
okay. So then we have two kinds of reduction, right? There's a closed reduction where even if the AT or PT does that, right, the physician will actually put it back in place and we don't need to do surgery, right? There's no need to open you up. It went pretty good. Open reduction means we reduced it and it's still not it's still not right, right? Maybe we need to put some pins or needles or something or plates to make sure that it stays there or that it's going to heal properly, right? So an open reduction, right, we have to open you up, and closed reduction is we don't have to open you up, right? So that's how I remember those. Questions, comments? Eric, what does calcitonin do?
It's a thing
Yeah,
that releases something. I forgot. Wait, hold on. Give me a second.
I believe in you. Let me know when you remember.
Just keep going, and if I remember, I'll let you know.
Okay, so after you have a fracture, right, everyone knows you immobilize this. Usually people come out in a sling or a cast or they have a little scooter, right? The bone needs time to repair itself. So we usually put in, even if we do have to do surgery, we put in a plate or a needle or a pin or something, and it does its own thing, right? Your bone actually heals itself. We just make sure that it's put there so it's in the right spot, so that it heals in the right place, right? Because your bone will adapt to fix it wherever it is, so that you could probably try and use it, right? But we're gonna make sure that it try and works normally as it should function, right? So it needs time to repair, okay? And why does bone repair semi-quickly? Eric, I need your UID in the chat whenever you,
000.
nope,
Oh.
nope, in the chat whenever you have a minute. You can do it privately. Why does bone repair faster than like cartilage?
Because it's more vascularized.
What does vascularized mean, Eric?
It has blood vessels.
I'll take that. I'll take that. It has blood flow, right? It has nutrients for sure. Boom. All right. So there are stages of repair. So first we form, we'll talk, I'll look at these. Thank you, Eric. We'll look at these and then I'll show you a picture. Okay. So you have a hematoma formation. That's the first thing that happens, right? Then you have a fibrocartilaginous callus form, right? And then you have a bony callus form, and then the bone remodels. So I'll let you all write that down, and then I will show you the pictures. Actually, I might just show you a couple videos. What did you get in the ice cream truck, Eric? Anything fun? Did you get like a SpongeBob one with the eyes and stuff?
Not good. It was just this chocolate like you know how the soft serve ice cream type thing,
Uh-huh.
but it's different there because it's super super creamy. Like
That's
super
good.
creamy.
I
And
don't
then-
get like the SpongeBob with like that.
yes,
Has it?
right. Or like the Bugs Bunny ones,
Yeah, yeah.
Uh-huh.
or
How
the
does
Rocket
the ice
Pops.
cream truck going around?
They're only limiting it one like family at a time,
Oh,
so you're not allowed to go close to it until
Social
everyone's left.
distancing.
I was
Ice
there
cream.
in my neighborhood.
That is wicked funny, actually.
I used to taste them when I was a kid.
Oh, I remember that. It's very identifiable. Okay, so let me know when y'all are done writing this, and then I'll show y'all the thing.
I'm done.
Yeah, me too.
Okay, cool. Let us. All right, this thing is really, really irritating. Okay, so this is our hematoma formation, this first one, right? And then we form these fibrous tissue, right? So that's what all this is, right? The little white, they literally look like fibers. I'm not sure what else to say other than like tree roots. Okay, and then we make a bony formation, and then the remodeling occurs. So remodeling, which literally means we're redepositing bone, we're recreating bone. So first, our hematoma. Hemat means blood. Oma means tumor. So literally it's a blood tumor, right? It's just, we fill that with blood because blood has all the nutrients. It brings all our nutrients and our warriors to the site, right? It brings our lymphocytes, our macrophages, our mast cells, anything that needs to go there, our blood brings. So we bring a lot of blood there, right? Because we've broken it. And then once we started to do that, we make fibers, right? That's like our first sewing. If we're sewing it together, right, then we sew it with like a little needle and thread, and then the bone comes in and it starts to harden, right, so that it actually has function again, and then we just fix it all together, right? So in this picture it looks like it's just trabecula, right? The fibers go from fibers to trabecula, and then this is where we make that compact bone and we actually finish it. Does that make sense? I feel like the picture is really like makes it much easier than like the words do. Yeah. Okay, let's see. Trying to see if this would give me. Okay, so cool. All right, so then for fractures, right? So non-displaced, meaning the epiphyses have not moved. Okay, Eric, I think this is before you got here, right? So the epiphyses has not moved. This displaced one, even though it's just a little, right? The epiphyses are not exactly where they were. Okay. Right? And then how the completeness of the break, right? This is completely through the bone. So this is a complete fracture, right? This is not completely through the bone, so it's incomplete. You don't need to know those. And then you need, yeah, they hurt. And then, right, compound, right? It comes out of the skin, right? And then simple, it does not. It's broken, but it doesn't come out of your skin. Okay. Okay, cool. Let's go back. Do we have, oh, wrong way. Sorry, I know I'm moving you a lot. How do we feel about that? Do we have any questions about that before we're gonna like talk about each stage? Very cool. Everyone is cool. Cool. Okay. So the hematoma formation is literally torn blood vessels, hemorrhage, right? Where we make this mass clot called a hematoma. Hemat means blood. Oma means tumor. Okay. So the site is swollen, painful, and inflamed. Right? I've never broken a bone, so I don't actually know, but I have a feeling that anyone who's ever broken a bone will remember this probably pretty vividly. Gonzalez says yes.
I've had a stress fracture.
Never had like a real break.
Yeah, I know.
I broke my toes playing dodgeball, if that means anything.
Eric, what did you break? Because I thoroughly believe that you broke something.
Calcitonin regulates the Ca+2.
Okay, in what direction? Does it lower it or increase it? I'll take that it has to do with calcium, but tell me which direction. Does it decrease the calcium levels in the blood or increase the calcium levels in the blood?
Is it breaking down or building up?
Okay.
Decrease.
Okay, so it decreases the calcium in the blood, which means, is it building or breaking, Eric?
Building.
Yes, tell me why.
Because
I
it's
know you.
putting it back in.
I don't even need to teach you. I vote you teach the whole class.
Yep, I'm amazing.
Good, good, good. Okay, so comedic relief. So, right, first we make that big blood clot, right? Second, we make this fibrocartilaginous callus. I know that's like a lot. That's a mouthful. Okay, so this is where our capillaries grow into that hematoma, right? And then the phagocytic cell, right, is just debris. That's what I said about your lymphocytes and your macrophages, right? Anything that's not supposed to be there will get taken away, right? Especially because we're having a break. So maybe it's complete and we get some dirt in there, or maybe it's just bacteria or it's interstitial fluid. Anything that's not supposed to be there will be phagocytized, right, by that cell and get rid of it, okay? So then your fibroblasts start to secrete collagen and connect the ends. So it's starting to make that weaving kind of like intermittent tissue, right? Like when you get a scab and then there's like that weird tissue that's not like your skin, right? But it's like the scab that goes over it. That is what I would compare to this like fibrocartilaginous callus, right? It's like the between. Okay. All right. And then bone is reconstructed because fibroblasts, osteogenic cells produce fibers and collagen to start reconnecting those bone ends. Okay. And so the mass repair of this is called a fibrocartilaginous callus. Does anyone remember what an osteogenic cell is and how is it different from an osteoblast?
Like creates, right? Or something like that.
It does. Why does it make it different from an osteoblast though? It's okay if you don't know. Just trying to rehash. So an osteogenic cell is it's a stem cell. So it's a cell in your bone that can differentiate into anything, right? So it's pretty much like a blank slate, and whatever we need, we can use this osteogenic cell to differentiate, which just means become something else. So it's going to pick a pathway, right? So that's a little different. Osteoblasts only make bone, right? But an osteogenic cell could become anything in the bone that we need. Does anyone remember that now that I'm saying it?
Mm-hmm.
Yes. Cool.
I do.
Yeah, because you made that thingy, whatever it says, osteoblast, bone lining, and stay. Yeah.
Yes. Eric, proud. Okay. So now we're on that 3. We're making a bony callus. We have that fibrocartilaginous callus, right? That's starting there, and so it's kind of connected it, right? And now we're going to do that bony callus formation. So within 1 week, which is, I don't know about y'all, that's wicked fast, right? Within 1 week, we start to make new trabecula, which appear in that fibrocartilaginous callus. So where there are fibers, the trabecula will start to grow and create actual bone, okay? Okay, the callus is converted into a bony callus of spongy bone, right? So I said that, I'll go back to the picture in a second. We'll relook at it, right? It converts into spongy bone first, right? That's where all those trabecula are. So we don't have that compact bone on the outside yet, that protective bone. We just have a lot of spongy bone. Okay, and then the callus forms for about 2 months until it makes this firm union. So y'all, that's pretty fast. Once we make a fibrocartilaginous callus, it's about like 2 months until we've actually made bone in there. That's wicked fast for like breaking a bone. Don't know about you, I think that's pretty impressive. Sorry, it's good. Okay, so then we start to make the actual bone remodeling. So, right, it begins during the bony callus formation, right? So the excess materials on the diaphysis, right, are removed, and that medullary cavity is reformed. Okay, compact bone is laid down on the outside or the shaft walls to protect the outside. And then the old structure resembles the new structure. Sometimes there are bumps. A lot of people have broken their collarbones, and you can like feel very specifically where it's broken because there might be a little ridge, but usually it resembles the old structure and it still responds to mechanical stress and will change however we need it to. So it goes back to its usual function, which is very cool. Questions before we do bone disorders? I'm gonna go back to that.
It says callus is converted into what? Form
I
what?
think it's bony, and then it's supposed to be parentheses hard.
Hard. Okay.
I think I might have just like made a small parenthesis, and I bought whiteout. That's
I
fine.
thought I said hand, but I was like,
Yeah.
confused. It's like bony hand. That does not make sense.
Yeah, no, for sure. Okay, so I'm gonna go back to this. Okay, so right, we make this hematoma, right? We clot, okay? And then we start to make those fibrocartilaginous things with osteogenic cells and all that stuff. And then we literally make, you see how this is spongy bone, right? It's trabecula, okay? It's not this compact bone. If you see the difference between this top piece and the break and the fracture site, you can pick between fracture and break. That fracture site is just spongy bone, okay? And then we actually create that medullary cavity again, and we put that compact bone on the outside. How do we feel about that?
Feel great.
Stellar. Thumbs up. Good, 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 good. Okay. Okay. So now we're going to talk about bone disorders. Okay, so bone disorders are imbalances between bone deposit and bone resorption. So pretty much that means that the homeostasis of our bones is off. We're either depositing too much, or we're not depositing enough, or something is happening where we're not in the right we're not maintaining. So we either have too little bone, it's too weak, or we have too much and it's too hard, right? So our bone deposit and our bone resorption, right, are really the reasons where we have a lot of bone diseases. Okay, so there are three main diseases that we're going to talk about. We're going to talk about osteomalacia, we're talking about rickets, and osteoporosis. Is anyone killing their family yet? Is anyone at home?
I'm not home.
But I'm home by myself all the time. My mom works.
Oh, that's actually a win.
I'm at
I
my
have 7 siblings.
Oh,
I want to kill myself daily.
Go.
no, we're not going to kill ourselves. But, wow, wow. Okay, I have like one roommate and one boyfriend, and I want to kill them all the time. So, you know.
Like, could you imagine living with like 7 Austins? That would be crazy.
Ooh. Okay. Gonzalez, are you at home?
Yeah, I'm at home, but
Do you get along with you?
I'm on the top floor and everybody else is on the bottom floor, so I'm by myself up here most of the time.
Oh, that's
I just
good.
made everybody.
That's a W. I would, yeah, no, Okay, so osteomalacia, rickets, and osteoporosis. Does anyone know about any of these? I feel like we've heard of osteoporosis a lot.
Mm.
Yeah, cool.
Yeah, the commercials are annoying.
Eric, that means you're watching old people channels. You know that, right?
My grandma has a remote most of the time.
Yeah, that's why you're getting osteoporosis commercials. If you turn on like an Adult Swim, you'll get a bunch of e-cigarette commercials. So like it's very interesting to see where they target this ads. But anyway, maybe it'll help you on your test. Okay, so osteomalacia, right? Your bones are mineralized poorly, right? The calcium salts aren't deposited correctly, and these are weak and soft bones. Okay, so we talked about how in the osteoid there's lots of minerals and bone salts, and so these bones are poorly mineralized, and so that makes them soft and weak. Oops. Okay, I'm attached to that. It's fine. Okay, so osteo means bone, and malacia literally means softening. So if you can remember what malacia means, then you know what's happening. Okay. Okay. Questions? I think I'm going to show you a little bit like some visuals on those in a second when I get through these. Okay, so then rickets is pretty much osteomalacia for kids. Okay, These result in bowed legs, right? And other deformities like large bone ends, right? This is caused by vitamin D deficiency or insufficient dietary calcium, which is why if you watch like, I want to say like TLC or something, right? Where there's like a lot of moms or HGTV, they'll have like those Ensure, or they'll have those commercials about those drinks that you can have your kids eat if they're not really good eaters to make sure that they're getting enough calcium, right? So y'all have seen people with bowed legs, right? Right, so that's usually because they had rickets as a child, and so their bones, especially their long bones, developed differently. Okay, so rickets is just osteomalacia for kids. So make sure the kids go outside and they're getting enough calcium. That's why they're always like, drink your milk, right? People really hound you about your milk. Okay. You're done writing. Can I go? Or you're not?
I'll take a big.
No, it's okay. Just I'm gonna post it online too.
Okay, I'm good.
Okay, fine. Okay, osteoporosis is the one we mostly know about, right? This is a group of diseases where resorption exceeds deposit. So we're taking more out of our bones than we're putting back in, right? So our bones end up being weak, right? So your matrix, right, ends up being normal, but the mass of your bone declines, okay? This is commonly seen in aged and postmenopausal women, and that's because of estrogen. Okay, so estrogen plays a role in your bone density. So after we lose it, so after menopause, when women start to have less estrogen, they're at a higher risk because that estrogen was doing a job our whole life, right? And so when we lose it, a lot of the time our body doesn't make up for it, and so because of that, we're at a higher risk to have osteoporosis because we'll have more resorption, right? It's almost like the feedback mechanism isn't working, right? We took away estrogen and we're still down here, right? We didn't adjust for it, right? Which is why they end up having to take a lot of supplements. Okay. So they love to ask about that. They love to ask because then it's your hormone is affecting your bone resorption, and they get to talk about that. So this is, I would star this. They really like to ask about estrogen and osteoporosis. Okay, so your other risks for this are when you're really small, right? Meaning you're probably not getting a lot of dietary fiber and calcium and things like that. When you don't exercise or stress your bones, right? So resorption is good for your bones, right? So it talked, I think in the beginning, it says like I don't want to scroll up the way up there. Every so often, your compact bone, spongy bone are renewed, like they're replenished. So that's good. We want to make sure that our bones are being recycled and they're continuing to be strong and build back up. So if you're not stressing them or exercising them, they're not going to be asked to do that as often. So they're not going to be as strong. Okay. Poor diet, low calcium, smoking, hormone-related conditions, immobility like bed rest, and then males have androgen-suppressing drugs when they have prostate cancer. I starred the ones that they like to ask about the most. So you have those, right? Okay, and so then we have Paget's disease, right? This is where there's haphazard bone deposit, right? So bone deposit and resorption. So this pretty much, does anyone know what haphazard means? No. So haphazard is pretty much when you wake up and your alarm is like 3 minutes before your class starts and you're running around throwing your hair up or washing your face or trying to brush your teeth and grab your keys and grab your phone, and everything's just like really frantic, right? We're not doing anything slowly or correctly. We're just like going as fast as we possibly can to get the job done, right? So we're depositing and resorbing bone like as fast as we can because we're like worried about a timeline or something. And so it doesn't get done well, right? It's like when you're trying to write a paper in 20 minutes and it should have taken you like a week and your paper's kind of haphazard, right? It's kind of rough. Okay. So this causes bones to be made fast and poorly, right? So they're poor quality. So it's called Pagetic bone because it's Paget's disease. Right? So we have a lot of spongy bone to compact bone, and we have not a lot of mineralization. So all of our ratios are off, right? So our ratios of salts and minerals and where compact bone goes and where spongy bone, all of it's not right, okay? This occurs usually in your spine, your pelvis, your femur, and your skull. Right, that's where it's most common, and it's usually in your 40s. So as you go on, a lot of the time, as you get older, your cells get older, and so they have a harder time keeping up with the demand. And then we don't actually know why it occurs. So they think it maybe be viral, but they don't really know why it happens. Are we done writing? Are we good? Okay, so we can start session 12. Let me show you some of these things. Did I put this in there? It did, okay. Okay, yeah, so. Right, so this is estrogen for osteoporosis, right? It ends up making weak bones, and so then we do a lot more, we do a lot less building and we do a lot more resorbing, okay, which makes these bones kind of weak and we lose bone mass. This is like, it's too much. That's too much for y'all. All right, and then, right, so we have excessive remodeling, right? And excessive, right, so it leads to deformities. Let's see. This is like, it's like a med school video, so it's a lot more than you need to know. So, right, so they end up misshapen, right? There ends up being a lot of issues with this Paget's disease because the bones aren't properly put together, right? They're not properly made. Let's see. Okay, you'll need to know that. We did this. Did I put it in the thing? Okay. What was I going to show you? I feel like that was what I was going to show you. Okay, so we can do a little bit of session 12 if y'all want to, because it's like 52. Do y'all want to start this and go just till we can go through we can try and go through synovial, or we can just kind of play it by ear and see how it goes. Is everyone okay with that? Okay. If you need to go, that's totally chill. Just make sure that, yes, 12 is on the website. Just make sure that you have left me your UID and that you are chill with me putting your face on the internet before you dip. Okay, so joints. I made this thing. Okay, so joints are also known as articulations. Okay, they're where two or more bones meet and their function is to hold things together and give mobility. Okay, if we had two bones touching, but there's no joint there, they serve no purpose, right? So just like if we have two bones there and we have no muscle attachment, then it still serves no purpose, okay? Why is this not working? So we need to have a joint to do the job of being able to allow the bones to move. Otherwise, there's no purpose, right? They're just there. And even if they touch, right? If anyone's ever had like a sports injury where they have like a tear of a meniscus or they have bursitis or something like that, if you've ever experienced something where your joint, where you're having an issue with your joint, you realize how painful it is to not have those pieces that connect the bones. Okay. So there's two classifications of joints. They're classified by their structural characteristics and their functional characteristics, right? Structural meaning what material binds it, and functional meaning what movement is allowed. Sorry. Okay, and then we have three classifications of structural, right? So what materials are made of? It's either made of cartilage, fibrous material, or synovial fluid, right? And then for functional, we have syn-movable, amphi-movable, or it's synarthrotic, amphiarthrotic, and diarthrotic. I just didn't write the whole thing. Synarthrotic means that they're not movable, right? Like the sutures in your skull are not movable. Amphiarthrotic are slightly movable. I feel like, I think wrist is amphi, and then freely movable, right? Like your humerus, right? Your glenoid cavity, right? In your shoulder for your arms and your hips. Okay. Okay. I'm gonna give you a second. So I think it's arthrotic. So it's like diarthrotic, amphiarthrotic, and synarthrotic.
That's an I. D. What?
DIA. Yes. Sorry. Can I move on? Are y'all ready or not?
I'm good.
Macy, are you good?
Yeah.
Okay. Yeah, I'm not rushing you. Okay, so then for our structural, we have fibrous. Okay, right? There's dense fibrous connective tissue. It doesn't have any joint cavity and it's immovable, right? It's pretty much protective. Okay. So then we have your cartilaginous, right? Where they're they're united by cartilage, right? They still don't have any cavity and they're not very movable. I think I'm going to give you some examples later in the packet. I can do this one. This actually works out good because this ends up getting into a lot of muscle stuff. So after we do these pieces, I'll show you some of these kind of joints. Okay, so then we also have synovial, right? These are the ones you're probably most common with. These are bones separated by fluid-filled joint cavities. Okay, they're diarthrotic, which means they're freely movable, and it's all your limb joints, and they have 6 unique features. All right, so this is going to be like your shoulder, right? Your knee, your actually I think your ankle is, and your hip, things like that. Let me know when you're done writing, and then I'll show you some examples, and then y'all can tell me whether or not you want to keep going for a second, or if you want to dip. Okay, so I think I'm done this way. Okay. Okay, so I know I moved you. All right, so fibrous, right? Like the sutures of your skull, right? We don't move the sutures of our skull. Cartilaginous, right? Semi-movable is those little pads between your vertebrae. Okay, so you can move those a little bit, but not that much, right? We have flexion and extension, but that's a lot of it. That is like hip movement and not necessarily spinal movement, right? If you've ever done yoga, you know that you can't move your spine that much. If you've ever done like camel where you're supposed to like lean back and you're like, I can't do it. I cannot do this. Okay. And then we have your freely movable joint, right? This is your pelvis and your femur. So this is your hip joint. Okay. Cool. Do we want to keep going or do we want to quit? Oh, you're not going to hurt my feelings. I don't care.
I'm good with whatever.
I can keep going.
Okay, we can go to Well, let's start with synovial joints because it's a lot, and then we'll reconvene. Okay, so your synovial joints have 6 unique features. These are your unique features. Okay, articular cartilage. They have a synovial cavity. They have the synovial fluid. They have an articular joint cavity. They have reinforcing ligaments, and they have nerves and blood vessels. Okay, so I'll let you write those, and then I'll talk about them. I'm sorry, this isn't bigger. I definitely should have made the boxes bigger, but what you gonna do? Gracie, how we doing? Are we good? You can give me a thumbs up, or you can say hi.
Hi, sorry, I'm doing good. I'm also
Okay.
doing some other homework on the side, my bad.
No, not mad. Just checking that you're chilling. I'm not
I'm
mad.
good.
I totally get it.
Thank you.
Sure. Okay, so for our articular cartilage, we've talked about how our bone originates as that hyaline cartilage, right, in the womb, and then we start to ossify that or calcify that as we go. So there's hyaline cartilage that covers the ends of the bones. What are the ends of the bones called? Macy, I believe in you.
Wait, the epiphysis.
Yeah, yes, epiphyses, whatever. Okay, perfect. Boom. If nothing else, you learn that. Okay, so your hyaline cartilage covers the ends of the bones. Okay, and then we have the synovial cavity, right? There's fluid that's very unique to the synovial cavity, right? So just like there's synovial fluid in your spinal column, and in other places of your body, right? There's a unique filled cavity, and so a lot of that cavity allows us to do the movements we do and not get inflamed. So if you play sports a lot, or if you've ever like taken a really long hike and then your knees hurt or your elbows hurt, or you know what I'm saying, something hurts, you might have some inflammation in that synovial cavity, because the purpose of the synovial cavity is so that it reduces friction and inflammation, because that fluid allows us to move that stuff around. I'll actually show y'all a video of that. We'll do these, and then I'll show you that little video, and then we can quit. Right, so there's a very unique fluid, okay, and then or the cavity for the fluid, and then we have the fluid, right, which allows us to nourish, lubricate, right, from inflammation or anything like that. And it also phagocytizes. It has properties of your lymphatic system, right? So that if something happens or something gets in there, it's making sure that everything is taken out or brought back in, or it's replenished. Okay, then we also have an articular joint cavity, right, which is our fibrous inner synovial membrane. Right, so we have lots of layers in this. Actually, it's the picture that I'll show you, because you have bursa and stuff, is really cool. I don't feel like they don't show you a lot of like pictures of your joints. There's like so much wrapping, and there's little like bursa, which pretty much are just like little sacks of articular cartilage and stuff that sit in different places, and it's packaged really well. It's really like an interesting thing, because it like wraps it and puts a little thing in there. And then we have reinforcing ligaments, right? We have capsular ligaments, extracapsular ligaments, and intracapsular ligaments. So extracapsular ligaments on the outside, and intracapsular ligaments are on the inside. And then we also have nerves and blood vessels, right? So we have nerves for pain, and we have capillaries that filtrate this says CAP, capillaries. So they filtrate the synovial fluid. So we have nerves and blood vessels. You know, if your shoulder is inflamed, you can tell if your like your metatarsals or metacarpals are inflamed. You can feel lots of pain in your joints, especially like if your lumbar spine hurts. A lot of the time that can do with your vertebrae, or it can do with your muscles, right? There's lots of pieces that go into that, right? Have you ever had like a shooting pain in your back and you're like, oh, right? Okay, let me show you this video, and then we can we can deuce. Okay. Actually, let's see if it'll give me.
You ever seen like when those bursa sacs like actually burst?
Yeah,
It's like
it's
a big
crazy.
bump on someone's
Yeah.
elbow.
Yeah. So here is kind of a picture, right? So I feel like they don't show you this, right? So there's all these fibers and there's like, this is a muscle attachment, right? This is the tendon of the biceps brachii, but then there's these little blue things, which are the bursa, right? Which actually allow for us to move and pinch and do all this stuff. So I think that's just like a really cool picture. So this is your shoulder, okay? So right, this is your clavicle, right? And this is your acromion under there, and then your coracoid right here. And then this is the head of your humerus, right? And then this is your glenoid cavity right in there. And so this is like all the attachments and wrapping that goes into a synoarthrotic or a synovial joint, which is like crazy. There's just like a lot going on. And then let's see. Oops. Okay, let's do a good picture. This, okay. Okay, so, right, so I don't really like this picture because this isn't necessarily, okay, yeah, let's do that. Because that wasn't like really a part of your body. So I just feel like that kind of sucks, right? So this is the head of your, or the bottom of your femur, right? And this is your patella and then your tibia. So you see how there's articular, oh, there's articular cartilage, right? And there's synovial capsules, and there's fat pads, and there's bursa, and we're going to talk about the fat pads and all that other jazz later. But these are all like synovial areas where there's synovial fluid in there, and then there's all these like articular cartilage that make the ends of the bone, I don't want to say soft, but like lubricated and movable, right? Like almost if you laminated the end of a bone, right? Right, where you couldn't rub it against something without it scratching. And then if you laminated the end of a bone, right, almost like articular cartilage, it would move pretty smoothly. Okay. Okay, are we okay to stop or do we want to keep going?
Good.
We ready? Let's do it, because this other features piece is, I think it's like a page and a half or something, because we do a lot. So why don't we just stop there and then we can finish this on Thursday. Yeah. And let me know if you need anything and I'll put the key on it, and every video or picture or whatever I showed you, it will be on YouTube or in the playlists. So
Oh, hey, your the lab stuff, it's on your website?
yeah, all the Quizlets, I think there's a link to my Quizlet page. And so I would just click on my name. I think it's like Peaches or something, because that's my nickname. And then you go and just find A&P Practical, whatever. Or I think it might be literally A&P Skeleton or something on there. There's also Lauren's Quizlets on there, and she has like a million. She has a million Quizlets. Yeah.
Cool.
Thanks, guys.
Thank you.
Thank you.
Bye. Have a good day, everyone.
Bye.
Hope you find your jazz.